Welcome to this webinar, which will look at upcoming changes to MBS chronic disease management. My name is Dr. Brendan Goodger. I'm the General Manager for Primary and Community Care. Today I'm joined by my colleagues from the Practice Support and Digital Health teams, Jan Sadler, Amy O'Halloran and Kylie Waldy. Firstly, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay respects to elders past, present and emerging. I'll also extend that respect to any Aboriginal colleagues who may be joining us here tonight. Please note that this webinar will be recorded and will be available on the CESPN YouTube channel, no less, within the next couple of days. At the end of the webinar, the evaluation survey will pop up in your web browser. We would really appreciate the feedback, so please complete this to allow us to issue certificates of attendance. Please ensure that you submit your questions to the speakers in the Q&A function throughout the presentation. To view this box, hover over the toolbar at the bottom of your screen. We'll be monitoring those questions, and there'll be plenty of time for Q&A in the second part of tonight. Well, it's now time to introduce our speaker for tonight, Wendy Amara. Wendy has a long history in general practice spanning 25 years. She currently works as a practice manager in a large 22 general GP practice in Gisborne, Victoria. She is passionate about general practice and has a thorough understanding of all facets with a special interest in MBS and chronic disease management. While working full-time, she still takes opportunities to meet and work with new practice managers, guiding them through the complexities of general practice. Wendy's been working as an education consultant since 2017. So Wendy, welcome to our webinar tonight. I think this is the fifth one that you've done. And so you're well versed in MBS. We're very lucky to have you. And so you will present for about the next hour or so, and then there'll be at least 30 minutes for some questions, and I'll help moderate that along with my colleagues, Jan and team. So Wendy, over to you.
Thank you so much, Brendan, and to everyone, welcome to tonight's webinar. Before I begin, I would also like to acknowledge the traditional custodians of the lands on which we are all virtually meeting tonight, and to pay my respects to elders, both past and present. And I also extend that respect to any First Nations peoples here with us tonight. So July 1 sees the biggest change in chronic condition management since the program was first introduced back in 2005. The Australian Institute of Health and Welfare data from 22-23 identified that 60% of people who visited GP in the previous 12 months had a long-term condition or health condition, and almost 1 in 6 Australians claimed a chronic disease item number. There's a lot of information floating around at the moment, and I will do my best tonight to simplify it, make it easy to understand, and give you an overview of what the changes mean to us in general practice. So at the end of tonight's workshop, you should be able to describe in detail the changes that are coming in less than 2 weeks now, July 1, 2025. Recall the new item numbers, rebates, and the claiming requirements, along with changes to the current referral process, and of course, understand the impact that this may or will have on your business and how you can best prepare to make sure you don't get left behind. So, chronic disease management, or chronic condition management as it's now called. From July 1, there will be a new framework for chronic disease management. The changes predominantly affect GPs, but it is important that allied health professionals also have an understanding of the new system, particularly around the changes to the referral process and the requirements to consent to participate. This program will have a transition period of 2 years in consideration of those patients who already have a chronic condition plan in place as of July 1. So what does it mean? July 1, the items for GP management plans, 721 is the most way we refer to them, or 229 if you're a OMP, and team care arrangements, along with the review of both, will cease. The updated framework will now be known as Chronic Condition Management, or GP, Chronic Condition Management Plan. So we'll just talk Chronic Condition Management tonight because it's quite a mouthful. So why? This change was in response to the MBS Task Force review, which recommended that the GPMP and TCA should be combined into one item number. Review of TCA billing identified that only 30% of those patients who were provided with a team care arrangement actually accessed allied health. They recommended the abolishment of the 729, and I'm sure there's lots of people saying, what's a 729? So that's been abolished as of the 1st of July. And what it is a GP's contribution into another provider's care plan. And probably the most common example of this is a palliative care team where the GP is engaging regularly around the treatment of a patient. The item 731 will remain, and as we know, that now forms part of the new aged care incentive servicing item numbers. And they also recommended that a copy of the plan be uploaded to the patient's My Health record. Now, it is not compulsory to do so, but if you're able to, or your practice feels that it's something they can manage, then it's recommended that happen. Access to allied health services will now be linked to the new GP CCMP item numbers. So the proposed descriptors, so changes to the descriptors from 721 to 965, basically the main change is that the item is available at the enrolled practice for patients who are enrolled in My Medicare, or to be performed by the usual GP if the patient is not enrolled. I still see that as that stopping of that opportunistic billing from practices where the patient attends once and walks away with a care plan in place, because the usual GP would mean more than one visit. It includes a coordination of team care arrangements where required, and requires the care plan to be uploaded to My Health record unless the patient's consent is withdrawn. So the patient may choose not to have that uploaded. Again, so 965, attendance by patient's usual GP and other health professionals in the practice. So it could be another provider at the same practice if the regular GP is not available or is on leave, for the preparation of a GP management plan and to coordinate any necessary team care arrangements. So it's basically 721 and 723 rolled into one item number, 965. The 967 has two requirements. Again, it specifies the usual GP or the practice in which the patient is enrolled. It also talks about the 3-month restriction. So similar to what we have at the moment, there is a minimum claiming period of 3 months, and it can be claimed 3 times in the first year if you're creating your new GP CCMP, and then 4 times in the next year. So the underlying focus of these changes are around regular review of patients with chronic disease. In fact, data shows that 55% of previous 721, 723s did not ever receive a review. So 721s and 723s were put in place with no review mechanism at all. Currently, reviews are reimbursed at approximately 50% of the fee for the creation of the plan, and reviews will be strengthened, ensuring that it's conducted by the GP at the practice where the patient is enrolled. So there's that continuity of care. By providing a higher rebate for the review, the goal is to encourage GPs to regularly review these plans. By claiming the single GP CCMP item number, or the 965, the patient will still have access to the same 5 allied health services they do in a calendar year, so from January to December. Nothing has changed there. What has changed, however, is the removal of the red tape around the collaboration process. So there is no longer a requirement to request collaboration from 2 providers. Previously, we had to have 2 providers in addition to our GP to ensure that we met the eligibility for the team care arrangement. That has been removed, and there is no longer that consent process. So allied health providers do not have to reply back saying, yes, I consent to participate in the care of this patient. So that is all been removed, which is going to certainly relieve the burden on the administrative side of chronic disease management. Along with the removal of that, there has been a rebalancing of the rebates for the items, and they have been balanced to be of equal value. So as we know, at the moment, a 721 is $160 and a 723 is around 130 something, whereas the reviews are only $80 or $82. So the rebalancing has brought the review rebate up to the same fee or the same rebate as the creation of the plan. So recap, basically, in summation, there's going to be items 721 and 723 and 732 will be removed as of the 1st of July and replaced with item number 965 for the creation of the GPCCMP and 967 for the review. They will be equal remuneration of $156.55. Patients will be eligible for this service whether they are solely managed by the GP, so they have a chronic condition that only requires the care of the GP, or require the input of a multidisciplinary team. So either or either, the item number is the same. The requirement to receive consent to participate and collaborate to the plan will cease, and there is an added requirement where possible to upload to the patient's My Health record. All right, there are the item numbers, and the 965 or 392, which is the OMPs or the PMPs, and then you also have the telehealth. So it is not telephone, it is telehealth. So video, any type of video platform can be used to do that. And then your 967, as you can see, is the same remuneration. All right, let's talk about now the requirements for the new GPCCMP. So as you know, with everything that we receive from Medicare, there are requirements we need to meet. So to prepare a GPCCMP, preparing a GP, I'm just going to say chronic condition plan, will be defined as preparing a written plan which describes A, the patient's current chronic conditions or conditions if they have more than one, and their associated healthcare needs, along with health and lifestyle goals as developed by the patient and medical practitioner using that shared decision-making approach, and of course, actions that need to be taken by the patient and the treating practitioner. So nothing's really changed in that concept, and there is no requirement, even though our practice software vendors are creating new templates for us, there is no requirement to use anything other than what you currently use at the moment because the criteria is still met with those. However, most software vendors are going to be supplying us with new templates to use, and I'm going to share one with you tonight that I have created for my practice. It's still a work in progress. It's obviously going to be updated and worked on, but I'm happy to share that with anyone who would like to give it a go in your practice. It also means treatment and services a patient is likely to need. So what treatment is the patient going to be required and who's going to be providing that service? If the patient would benefit from a multidisciplinary team care, the services the medical practitioner will refer to the patient to, so podiatry, physio, diabetes education, a listing of each service and who that service provider is, including what the treatment for that provider will be. Arrangements must be put in place to review the plan. Remember, the whole concept is that regular review. So basically you would set at the end of the preparation of the care plan, you would set the next review period, whether it be 3 months or 6 months. But the recommendation is a minimum of 3 months, recommended 6 months, but minimum of 3 months. along with the consent to upload to My Health Record if your practice chooses to do that, or if the patient requests it as well. If the patient is being referred to a member of the multidisciplinary team, the GP must also obtain the patient's consent to share relevant information. So you must document patient consented to sharing of information to diabetes educator, physio, and the relevant parts of the plan, which can be added to the referral letter. There is no requirement for the allied health provider to confirm acceptance of the referral or otherwise provide input into the preparation. As you know now, we are supposed to, and I say supposed to, wait for the allied health provider to send back what they're going to do, so their plan for that patient, and that should be added into the team care arrangement before we bill that service. However, the requirements for allied health providers to provide a written report after the provision of certain services, so the first service or the last service, has not changed. So there is no change in the feedback from the allied health. Should be after the first service has been provided and at the end of those 5 services to give the GP an update of where that patient is at with their management. The process of developing and finalising the chronic condition plan should record the patient's consent and agreement to the preparation of a plan. We should always obtain consent from our patients when we are preparing any kind of information that is going to be shared with others. Offer a copy of the plan to the patient. Again, that's unchanged, and the patient's carer, if any, and if the practitioner considers it appropriate and the patient agrees. So if the patient has a carer who's present and asks for a copy, it's absolutely fine as long as the GP and the patient agree to that. Adding a copy to the patient's health record or to their medical records, which is currently what we do anyway. And again, that uploading of a copy of the patient to the patient's My Health Record where consented. Just want to touch on that quickly. At the moment, there is our software, the ability to upload these is not there. So if anyone like myself has had a look at, okay, how am I going to upload these? There's actually no way to do it. So there is going to be some work involved, or need to be some work involved with the linking of My Health Record to enable GPs to actually upload these types of documents. We can upload consultation notes, and that may be the way they're going to go, where you just basically upload your notes, which is not really what they're looking for. So I'm hoping there's going to be some work between My Health Records and the software vendors to make that happen for us sooner rather than later. So here's an example of what the new plan may look like. So this is what we're looking at the moment, and it's just a really brief overview for you. But just so you're aware, and I can only speak to best practice because that is the software that I use, but they have already developed new templates for the GP-CCMP. Also, they have developed a review template and a referral letter. So that's great if you're one of those practices just likes to use the referrals that are or the templates that are provided by your software vendor. If you're like me, I like to make my own. So we like to make it very specific to our patients. Along with that, they are also adding enhancements which will assist us in identifying patients. So at the moment, we have to log into Proda and go to My Medicare to find out who is actually registered. So that is all going to be integrated. So there'll be a integration between best practice and Proda, which will allow automatic checking of whether the patient is registered for My Medicare, and if so, where they're registered. And there'll also be the ability to register them directly from the demographics. So that's going to be fantastic for future references for getting our patients registered, because as we know, most of this underlies that registration. Everything is linked to my Medicare registration. So we need to be thinking about that, and something like that's going to be really valuable to us for recognising patients who are not registered to enable us to register them. So that's going to be really good and something that's exciting. That's what they look like. So that's just a bit of a snippet from Best Practices webinar on how it will look. They've created appointment types. So you can see the bottom left, there is the booking screen, and there's a GP/CCMP plan and the review. There is a recall, and there's also a reason for visit. So each of those boxes is being ticked along with the templates that they have available to us. But again, as I said, you do not have to use those. You can certainly use your own. So we've looked at the creation of the chronic condition plan. Now let's look at the review requirements. I can't say it enough. The objective of the change is to encourage regular reviews of our patients with chronic conditions. So a lot of practices, and I'm not saying it's everyone, but a lot of practices would regularly give patients their new care plans in January when they came in for their 5 visits, and then that patient would not come back for 12 months, so there was no review. That is not best management of patients with chronic disease. We need to be regularly reviewing them in a structured approach. So these whole changes are hinged on that review process. An existing GP/CC. Brenda, do you want to ask something?
Yeah, look, we've got a great question in the chat, and it's just too good to let go.
Okay.
Which is currently, can you tell us around the reviews? Because it's currently recommended, nowhere does it say that it's recommended 6-month reviews in the MBS. The MBS states 3 months only. And one person has written that they've heard their colleagues mention the 6-monthly thing, which have not known since working here since 2016. So I wonder if you could tell us around the 6 months versus the 3 months.
Yep, absolutely. So I can refer to, I guess, perhaps my practice. So in my practice, we have patients who definitely require 3-monthly review, and we have patients who don't require 3-monthly review. So it's always going to be the doctor's decision. We choose some patients to do 6-monthly, others we do to do 3-monthly. So there is requirements at the current process. So we're going to talk in a minute about the transition process and how patients who currently have care plans in place will be transitioned to the new system with a minimum of 3 months. So at the moment, it's basically choice when you choose. So you can do them 3-monthly, but it is recommended 6-monthly. So each practice is going to be different, and I think in the process of the change of remuneration to receive at least the same remuneration receiving previously, practices are going to regularly review their patients, hopefully at the 3-month point. The other thing we've got to look at is whether we can get those patients back every 3 months. So it's going to be another hurdle to overcome, I guess. I hope that answers the question, Brendan.
Yep, please continue. Yep. Thank you.
Brilliant. Thank you. No worries. So an existing GPM chronic condition plan can be reviewed and amended on an ongoing basis. So every 3 months is the recommendation if you are under the new system. However, it is always going to be GP's decision. The new MBS item number to review should only be used to review an existing GP/CCMP, and I'm going to talk about that in a moment. If a patient requires a review of the GPMP and TCA that they have in place prior to July 1, they need to be transitioned to the new program before you can conduct a review. I'm going to try and simplify that because this point has created a lot of questions and a lot of unsurety about what it actually means. So patient has a 721 and 723 put in place today at my clinic. So they build a GPMP and a team care arrangement, and a reminder is put in for 3 months. Okay. In 3 months' time, I cannot do a 732 because item numbers have been removed. I cannot do a 967 because I don't have a 965 in place. So in order for me to review, or for my GPs to be able to review the patient's chronic condition regularly, they must be transitioned to the new 965 process. Yes, a lot of people believe it's double dipping, it's double work. We do a new plan today, and now we're going to do a new one in 3 months' time. I agree 100%, but that is the way it's going to work. So anyone who has plans in place prior to July 1 will transition to the new system when they are due for their reviews. If your GP had put a 6-month review in, then they would be reviewed. They'd be transitioned over in November if that was 6 months' time. So there has to be a minimum still of 3 months since the 721 and 723 was put in place before the patient can transition to the new 965. I hope that makes sense, because there was a lot of confusion even in my practice. All my GPs were interpreting it in different ways, but we've all got together and decided that this is what they mean, and the information coming out now is basically supporting that if they have plans in place, they do not need to be transitioned if they don't require reviews, if you're a practice that doesn't review regularly. However, if you are going to review the patient's care plan, you must transition them over to the new chronic condition management plan. Unless exceptional circumstances apply, a GP CCNP can be reviewed every 3 months if it is clinically relevant to do so. So it's someone who mentioned the Medicare guidelines, that is basically what it's saying. If it's clinically relevant to do so, you'll review it 3 monthly. That's where I'm getting the 3 months and 6 months from. Sometimes it's not relevant or appropriate to review because nothing at all has changed. But reviewing a GPMP or GP CCNP means that the GP must document the patient's progress in relation to the original goals. So the goals were set when the new plan was created. Part of the review process is that there must be documented progress against each of those goals and whether any updates should be made to the GP CCNP. So were the goals not being met, and if they weren't being met, why, and what do we need to change to ensure that patient continues to manage their condition. We also need to take into account, as I said, whether the goals remain appropriate and the degree of progress towards those goals. So goals should be set in collaboration. Patient and GP decide what the goals are for that patient. Then we need to, at the review process, decide whether we got it right. Are they appropriate for this patient? Did they not meet them and they feel that they've failed? Or were we setting too high, too much, expecting too much of them? This is the process we would now look at and say, great, you've done really well. Or okay, we're not where we'd like to be. Maybe we need to change things around a bit. Information provided by members of the multidisciplinary team. So any feedback that the GP has received as a result of referrals to a multidisciplinary team should be taken into consideration. And the extent in which those services are supporting the patients to meet the goals. For example, if they're going to the podiatrist or they're going to the exercise physiologist, and yes, the EP has now got them to walking, where they're walking, 10 minutes instead of 5 minutes or 20 minutes instead of 10 minutes, then yes, those goals are, the process is working and the patient is working towards their goals. So all that needs to take place when you are doing your review. Same process when we're looking at the requirements. Patient must consent and agree to the updates. Again, offer a copy of the updated plan to the patient and or carer if appropriate. Add a copy to the patient's medical record and the uploading of those patients if again we've got it right and we can actually do it, and if the patient consents. So there is still some work to go with the My Health record. Just for clarification, what is a multidisciplinary team? So for the purpose of the chronic condition management plans, a multidisciplinary team member is a person other than the GP. So any other provider that provides care for your patient besides the GP. They provide a separate service, so a service to the patient that's separate from the GP, and they are not a paid, so is not an unpaid care of the patient. They do not need to provide services under Medicare to be a member of the multidisciplinary team. What do I mean by that? Meals on Wheels, district nurse, all those services that are not MBS claimable can still be part of the multidisciplinary team. Now we know what we've got. Let's look at how we're going to transition to the new system. And as I said to you before, patients that have a GP management plan and team care arrangement in place prior to July 1, will still be able to access services consistent with those plans for 2 years. Now, this is where a lot of people got confused, because on one hand, we're saying we don't need to do anything. On the other hand, we're saying we need to transition them. So this is what I wanted to clarify. If you have a patient who has a 965 and 721 and 723 in place today, and you do not see them for 18 months, they are still able to continue to access the allied health services that you referred them for without a review. So there's going to be, you don't have to review them for them to continue to obtain the services under the 721, 723. As of July 1, however, a chronic condition management plan will be required for ongoing access. So once that patient has used their 5 services, so we're into July, many patients may have used half of them, all of them. They obviously have to wait till January to get more. But come July 1, any patient who requires a new referral for new allied health services will need to be managed under the new system. Patients can still continue to access services provided by the 10997, so the nurse item number, or the 10987 for Aboriginal health workers. So that hasn't changed. The 10997 has not changed and allows those 5 services per year that the nurse provides to assist the GP in the management of a patient's chronic condition. That has not changed. But as I said, if a patient requires a review, that was put in place. So 721, 723 today, the GP would like to review it in August. In August, the patient will need to have a 965 put in place to then progress to the review stages after that. The other interesting thing has been advised is that from July 1, 2027, so that 2-year transition period from July 25 to July 27, after that 2-year transition period has expired, GPs will not be able to refer for a medication management review. I can never say that word. I should put home medication review, unless they have a 965 in place. So if you are referring regularly for medication reviews for your patients, yearly, 2 yearly, whatever you feel is appropriate, come July 1, if they don't have a 965 in place, they will not be able to access that service through the MBS. So we've covered off basically on what's coming. I want to talk about the changes to the referral process now. So referral requirements for allied health services written on or after July 1 will change. Those changes will ensure the requirements are consistent. So what we're looking at is consistency across the referral processes in general practice. Any referrals for allied health services written prior to July 1 will remain valid. So there's no reason to redo them. So if you used, and I say the word EPC, I know the actual program EPC has been gone for nearly 10 years, but everyone knows what I'm talking about when I say the EPC referral. So prior to July 1, we were using the EPC. This will remain valid until the patient has used all of the services nominated in that referral. However, from July 1, any referrals done from that period will transition to the new process. Basically, consistency. They want GPs to be doing referrals that are the same across the board. Allied health specialists will all be the same format. There is no requirement for allied health providers to say, yes, I've got the referral, I'm going to take it. So as you know, at the moment, we've still got that, yes, I agree to participate, I'm happy to see that patient. That is no longer necessary. And unless otherwise specified, the referral now lasts for 18 months instead of 12 months. So previously we had our 12-month period, which is where we would do our new plans. Unless the GP says, no, I would like this referral to be for 12 months, it is valid for 18 months, which means that patient has 18 months to use those 5 services. The new referral requirements apply to everything, so chronic condition and any allied health services that are referred to from the chronic condition plan. So the new referral requirement will apply whether the referral is written under the new GP-CCMP or whether the patient is still being managed under the old system. So the 721, 723, regardless of whether that patient continues to be managed under that, the referral process changes on the 1st of July. What should the new referral have? Basically, the new referral has requirements, and they must have the name of the referring practitioner, including the address of the practice and the practitioner's provider number, include the date on which the referring practitioner made the referral, be in writing, and be signed by the referring practitioner. And it can be an electronic signature. So it doesn't have to be printed out and signed before you can, email it off. It can be an electronic signature. It needs to explain the reasons for referring the patient, including any information about the patient's condition that the GP referring for services believes is necessary to the allied health professional. So the referral should include information relevant to the podiatrist or information relevant to the dietitian, so specific information. One of the objectives of the change is to give the patients flexibility. So as of the 1st of July, referrals do not need to specify the name. They can say, "Dear podiatrist," or "Dear physio," or "Dear exercise physiologist." This change has been made in recognition of patients' flexibility and giving them choice. So if the patient has a preferred provider and they want the referral made out to them, absolutely fine to continue to do that. However, if you give a referral to a patient for a physio, they have the choice as to where they take that referral. They don't have to take it to the physio that comes to your practice or to the physio that you've recommended. So it's giving patients that additional option. And that's why it's so important that allied health providers become aware of this new process, because if they get referrals, they're going to say, "This needs to be changed. It doesn't have my name on it." So we need to be ensuring that allied health professionals that we are referring to are aware of the changes as well, so that they know that the referral does meet the guidelines for the MBS. The other thing that the referrals don't need to have is the number of services. So I'm not really happy or not really comfortable with this one because it's going to cause a lot of confusion. But basically what they're saying is you can give a referral to a patient with no name on it and no number of services. We're going to continue down putting the number of services, if nothing more than just to keep track of who we referred to. But the requirement to put the number of services has been removed. Again, GP's choice. It would be much better to keep track of things if the services allocated were written on there. Where the allied health provider is known to the GP, they're encouraging that electronic referral process. So push of a button and the referral gets sent off to the allied health provider to minimise the risk of lost referrals. However, only possible or should only do that with the patient's consent, because they might want to take that referral and source their own provider. So if they say, "Yes, this is the provider I want," absolutely put the referring details, put the allied health's name and email it directly to the allied health provider. However, if the patient's not sure, then you can just you can even email the referral directly to the patient and they can take it to whichever provider they choose. So I do want to also talk about the 10997 because again, that gets mentioned. There's a lot of confusion about what does it mean. So basically, as we know, the 10997 is the role of the practice nurse in the supporting of a GP in the management of a patient with chronic disease or with a chronic condition. Nurses play a vital role in that management and ongoing review of the patient. And by offering the nurses to support the patients in the preparation of the new GP-CCMPs and the reviews, gives a more structured approach. This item can continue to be claimed. It's not going to be removed. There's been a lot of, is it going, because I think somewhere along the lines it says in the new descriptors or in the new handouts that the government's made available to us, that the 10997 can be managed, can be used for the remaining 5 services. There is no change to the 10997. However, I do want you to be aware of what the actual requirements are. Because, you know, as for those who may have remember a few years ago, there was a bit of a lot of nudge letters went out to GPs. Please explain why you're billing the 10997. I'm not going to spend a lot of time on this, but I'm going to provide this in a PDF format at the end for anyone who'd like it. But this basically gives you an overview of when you should be billing a 10997. And I want you to focus on the very last paragraph where it says the 10997 should not be billed with chronic disease, anything. So not in the creation of the plan, not in the review of the plan. The service is based for the practice nurse providing the GP support around the management. So it's basically clear as mud there that it tells you that you are not to use the 10997 when you are either creating or reviewing chronic disease plans. This is the flip side of that document, and it basically gives you what you can. You can claim a 10997 where the service provided by a practice nurse is separate and clinically relevant service that would not be considered a component of developing or reviewing a CDM plan. So I hope that makes it clear, because there's a lot of confusion, and with confusion comes reluctance to bill. So GPs like, I'm not going to bill it because I just don't know whether I should be or shouldn't be. So I'm hoping this will clarify that or change how you're feeling so that you are more likely to bill it when it is appropriate. So I will give you a full copy of it for you to have a look at and take, show to your practices. Now, what I want to look at now, there's been a lot of talk about we're going to be so much worse off, we're losing so much money. So I want to give you some comparisons of what we have at the moment and what it may look like depending on how your practice works. So let's look at currently at the moment, as you know, to provide a new 721, we receive $164.35 and we're able to bill that once a year. Again, recommended 2 yearly, minimum claiming period 12 months. Then we have the team care arrangement, which is $130.25. Giving us a current Medicare rebate without any bulk billing incentives of $294.60. Now, if you are a practice that only does 721s and 723s when the patients come looking for them in January and do not review them at all, in a practice that manages 2,000 patients, your remuneration for those services currently is $589,200. So that is what you're getting every year for putting in place two 721s, 723s, and not doing any reviews. So that is some practices. Then you have the next type of practice, who again does the new plan and the new team care arrangement. However, they also regularly review. So every 3 times a year, they review the 721 and they review the 723. Same practice. The remuneration is $1.5 million. So 3 times the amount for those practices who only did 721s and 723s in January. So there's your 2 scenarios. Practices that at $589,000 who reviewed once a year, practices who review regularly, $1.5 million, based on 2,000 patients. Now let's look at what we're going to have under the new system. So under the new system, $156.55 for our new plan, and then $156.55 3 times per year when we review those patients 3 monthly. It gives us a rebate of $626,000, which equates to $1.25 million. So if you are practice A, who was just doing the care plans every year and weren't reviewing them, you are going to be $700,000 better off. However, if you are the practice B, who did the plans yearly and reviewed them 3 monthly, you're going to be around 300,000 worse off. So it's not as bad as we first thought. It depends on your system. And again, that whole process of ensuring you are reviewing your patients regularly, not just for the remuneration, but it's best practice for those patients with chronic disease. They need that regular structured approach to their care. Otherwise, they tend to slip off. If they're left a year, you're back where you started from. So underlying all of the incentives coming, not just the chronic condition management we've got coming in July, but the mental health changes coming in November, are all related to My Medicare. So there's that whole underlying theme of patients being registered for My Medicare. So most practices, when the system first came in, they were really gung-ho and I got lots of patients registered. And then when the aged care incentive came in, we got all our aged care patients registered, and then life took over and things got busy and those enrollments have sort of, dropped off a little bit. It may not be that for your practice, but many practices like, okay, I'll get back to that one day. So now is a perfect time to start that process again, because as I said, this will hinge on the ensuring that you are the only practice that will be able to bill those services or the new services. So if you haven't already, the first thing to do is enroll your practice with My Medicare in Proda, because all new incentives rely heavily on registration or patients linking themselves to your practice. Educate your staff. So there's any practice managers here tonight, this has become my passion, is to make sure my staff know the conversation, how to start the conversation and how to ensure the patient understands the benefits to them. May not be to them, it could be there to their family or to their mother or to a spouse. So remembering that, not all patients are going to benefit from this apart from the long phone consultation. Your reception staff, your nurses particularly, have got a vital role in playing and engaging these patients. If they're managing them with their chronic disease or their chronic conditions, if they're reviewing them regularly on behalf of the GP, they are in a perfect position to have that conversation with your patients. Make sure all your providers are linked to your organisation in Proda. So August is coming up, we've got new registrars starting. Make sure that you have those providers linked. It's not just about, you need to make sure they're all linked in your Proda account, so that when a patient tries to register with that provider, they're actually able to access. Because if they're not registered or not linked to your practice, the patient won't be able to register with you. So starting that conversation is so important. Sometimes it's difficult. So that's, as I said, has become my passion, I guess, to educate my staff on how to have that conversation with them. Encourage enrolment. Don't make it sound like a tedious thing. Encourage that enrolment process with your patients, but offer transparency. Say to your patients, by you registering with our practice, or we'd love for you to become part of our practice family, and we've been looking after you for a long time. However, there may not be anything available for you incentive-wise at the moment. However, future incentives are coming, particularly around mental health, and it will allow us to provide those services for you if you're registered. So we have got now chronic condition and mental health. So I don't know about you, but 70% of our patient population is around chronic disease and mental health. So it's a big chunk of our practices that will be linked to this registration. You can put links on your website. You can have a QR code at your reception or in your waiting room. Some of your online booking platforms will actually allow the link to be embedded into their booking system. Have handouts at reception. Don't make them complicated. Those simple 3-step instructions on how to quickly register. Or the simplest thing is have the forms there and say to the patients, while it'd be great if you could register yourself, if you're not comfortable, if you fill this form out, we'll happily register for you. So make sure GPs have access to the registration form so they can get those patients to sign up when they're with them. Don't forget about your new residents in the aged care facilities. So, in August last year, we signed everyone up that was registered, but patients may have come and gone in that process. Are you capturing those new residents that come into the aged care homes? Have you got a system in place to ensure those patients are registered under the My Medicare and the aged care incentive? So think about that. What systems have you got in place to ensure that obviously your best practice, those new enhancements coming in July are going to make a huge difference to the way we check. Anyone will be able to click a button and check patients whether they're registered, and if not, can help the patient register through the software itself. So that's going to be a real benefit to us. Obviously, going into Proto, you can still go to Proto to manage your registrations, but think about also how you're identifying. So a lot of practices have got, they're handing out forms left, right, and centre. They're encouraging patients to register, but they're not taking that next step and seeing, oh, yes, they're registered. I need to let the software know. I need to let the GP know, so that they're now eligible for those long consults, or they're eligible for the chronic condition. So obviously the integration will come, but how are you doing that now? Do you have to go into Proto and then look at your list and then go back into your software and click the box to say registered for My Medicare, which is how a lot of practices are still doing it. So make sure you keep that up to date so that your data is current. This is what I used at our practice. I'm happy to share it. It's basically something I printed in A3 form and put on the wall, and patients looked at it, read it, and come up and said, yeah, I'd like to, how do I register for that? So, or can I, we had the forms attached to it. So patients were bringing it, and it's certainly improved our registration process, so how many patients we were able to register. So keep that in mind. If you'd like to use it, or you could create something simple. Obviously, it will be updated now to include the chronic condition changes, and come November, updated again to reflect the mental health changes. So ensuring your data is correct is essential. Making sure you have cleaned up your data, so that if you're starting to look for patients to prioritize, or to patients to engage, you need to sort of make sure your data is clean. So archive any patients who haven't been to your practice in the last 2 years. Run a list to make sure you haven't got duplicate patients. So clean that all up. Clean up any free text diagnosis so that your chronic condition diagnosis is correct. Recording usual GP. Most of your clinical softwares have a spot for you to record the GP. It helps when you're looking at, who those patients should be registered under. Use your clinical software to run reports on patients who require long appointments, or patients with chronic disease. You can use PenCat, Polar, or Best Practice Medical Director, whatever software you have on board at the moment. And billing reports. So making sure that chronic disease, that patients with chronic disease that were billed in the last 2 years, so that you can sort of start to focus on those patients coming up to the changes. Look at where you are. Okay, I've got 50 patients who are due for new care plans. I'm going to wait till July 1, and I'm going to get them all in, and we're going to run that process and get them started off in the new year. And those patients who return regularly. Don't forget the aged care home, making sure that you're keeping up to date with that, and that you have got all those patients, lined up, and that you are keeping them up to date with the registrations. And then decide how you're going to invite the patients. Are you going to send them a letter? You're going to send them an SMS with a link to the registration form? Are you just going to have the conversations in your practice? You could give the GPs in your practice a list of their current patients and get them to have those conversations with them. And of course, the admin staff are valuable in that discussion. If the forms are sitting on the patients at the desk in front of the patients, and the admin staff need to be aware of what it is, so that they can actually have that conversation. So really important, practice nurses play such a vital role, because they, particularly around the chronic condition changes. So patients are going to be coming to see your nurses regularly still, they're the ones who are ideal to have those conversations with the patient. So have, get them engaged and explain to them what the benefits are for registering with them. Remember, with the My Medicare, there's that voluntary process. So the patient can withdraw at any time, and we need to make sure we're keeping an eye on that. So that's where those enhancements in our clinical software will help us, because they'll be able to identify any patients who may have registered or deregistered or moved on to somewhere else. So those aged care homes, we made it part of our admission process. So when a new resident is admitted to the facilities that we look after, the CMA is printed, and along with it comes the My Medicare form. It's been attached to the pro forma or to the template, so therefore it all prints together, and that allows the patients then to, or to the GPs to remember to do it when they go up there. So I'm going to now invite questions. So I've got some resources here, which I'm happy to share with all of you. There's lots there to look at. Basically covers off everything. I know there's lots of information at the moment, so it can be a little bit overwhelming, but I find often the easiest way to do it is to actually do the reading yourself, so that you're sure you know what your practice wants to do. So Brendan, do we have any questions?
Yeah, well, look, Wendy, and thank you for an excellent presentation. And you've got through so much so quickly, and there are a lot of questions in the chat.
Good. Yeah.
So how about you and I work through those together, perhaps?
Yep, sounds good.
And we might start off at the very top, which is, can you explain the scenario where a GP management plan has been completed on the 18th of June 2025? And as per the old system, the various members of the team have been invited to contribute. What happens when we only get feedback from the members of the team after July 1? And the comment is...
Yeah, very good question.
Yeah, I'll leave that with you.
Very good question. So if that was my practice, and this is just a suggestion, we have already thought about this, and that's a very good question. So just for those who are not sure what that means, basically, as you know, when you do your 721 and 723, you should not bill your 723 until you have received collaboration from the other providers. So if the collaborators are slow and don't get back to you in the 11 days you've got, so what we've been doing from now since I guess 2 weeks ago, we've been recording every person that we send it to, and we have got someone actively following them up and saying to them, you must please send this back to us so that we can get these services, because as you know, if you don't bill the 723, the patient can't get the rebate. So, we say you need to get us feedback, and we've been successful. It's actually worked. So it is a little bit more work for our admin staff, or you could put something on your fax, change your fax to say, dear provider, please ensure you return this directly, straight away, so that we can ensure processes are put in place prior to the 30th of June. So allied health providers who may not be aware of it may start the conversation, but that's a very good question, and it's certainly something that you need to consider between now and then.
I think that's a nice pragmatic response, Wendy, so thanks for that. The next question is, what happens if a patient does not return after the first visit for the EPC and the CDM?
Sorry, I'm not quite sure what that means.
So we're saying if the patient doesn't return, so is the GP then getting a pay cut for doing the CDM? The patient may not turn up every 3 or 6 months.
Yeah,
because they don't have time to fill the need.
Yeah. And that is always going to be our challenge. So on one hand, we've got practices who want to do the right thing and review their patients regularly. The other problem is patients get what they want and then they don't turn up. So I have a simple solution for that. Don't give them what they want. Give them 2 visits and tell them they have to come back in 3 months' time, and you'll give them another 2. Or you want 5 visits to the podiatrist. That's great, but referral processes have changed from the 1st of July. I can only give you 2 now. You will need to come back to be reviewed before I can give you any more. That will get them back.
Yeah. All right. Thank you for that. Again, that's helpful. Now, the other question is, do we call the patients back for a new plan after 3 months, or the patient presents themselves to get it and the EPC service is half the numbers used, right?
Yeah, and that's another good question. How are you going to manage this? So as a practice, we're a large practice. So how are you going to manage how do you know where you're going to be come July 1? So I would be starting already. So look, identifying patients who are due for reviews now. So anyone who's had a 721 and 723 in place for the last 12 months and have either had one review or no reviews, that's where I would start. You then book them in after July 1, transition them to the new program and put your recalls in place. So there's going to be that messy 2-year period, because as you know, we've got 2 years to transition everyone over, where patients who will not come back until they want something, which will more than likely be January, February, when they realise they can now access another 5 subsidised services. So start thinking about, we start off with just who has had a 721 and 723 build in the last 12 months and who was due for a review now. And we have just waited and booked them in July. The other thing we've done is we have moved them all to the nurses. So my GPs do their own reviews with their care plans. So that will simplify the process. The nurses will do the hard yards, creating and implementing the new 965. And then GPs should be able to regularly review them without having to get those patients into clinics, because that's where patients are sometimes hard to get back, when they have to come and see the nurse and then see the GP as well. So we just changed things around a little bit and decided the nurses will do the new GP CCMPs and my GPs will review them every 3 months, unless there's a significant change, and that has not changed either. So the minimum claiming periods are the same. However, if there is an exceptional change in the patient's clinical condition, you are able to bill a 965 earlier. However, because the rebate's the same, you wonder how many GPs are just going to start just constantly do the reviews and not even worry about the new plans, unless there's been a big change.
Yeah. Yeah. No, look, thanks for that. Just going to pick up another question here further down, which is, are we able to co-bill health assessment item numbers 705 to 707? Because what about mental health care plans? Where does that fit in?
Yep. So, all right. So at the moment, you can bill, say we look at today, you can bill a health assessment, you can bill a 707, a 721, a 723, and a 2715, if you meet the criteria for all of those things. There is no risk. The only thing you cannot claim with chronic condition plans is a standard consultation item number. So when we talk about mental health, a GP might come in, the patient might come into the clinic and the nurse prepares the plans for them. The nurse does the health assessment, and then the GP takes the patient in, and the nurse has identified the patient's got a few issues with their mental health at the moment. Through the whole process, the GP then can provide the patient with a mental health consult, but the minimum claiming periods must be met. So GP would need to be with the patient 45 minutes to ensure that the time spent meets the requirements for each of those services, and that each of those services have been documented clearly.
Yeah. Thanks, Todd. I just wondered if you could help just provide a bit of insight to this question too, from someone who's written, so their understanding is that the practices have done the right thing and regular reviewed patients will now be penalised financially in the new system.
Yep, exactly right. That's in a nutshell, yes. However, you now need to look at what you're going to do instead. So we are one of those practices. We reviewed our patients regularly. We will be worse off under the new system. So we have purchased an ABI machine. We've trained our nurses on spirometry. We've trained all our nurses in the ECG, and we're going to start implementing additional services to replace the remuneration. We've just looked outside the square and said, okay, we're not going to have the same remuneration. What can we do for our patients with chronic disease to improve their care? And
Yeah.
they're the things we came up with. So, spirometry for those patients with COPD or asthma, ABIs for those patients with diabetes or any kind of vascular disease, ECGs for patients with ischemic heart disease. There are ways you can recoup that cost. For example, an ABI, 2 services, wrist and ankles, $135, and the nurse does them for you. So think outside there. That replaces the income you've lost already. But I agree 100%.
Yeah, I think it's a real issue. And look, just to the people listening tonight, is that any questions that we don't get to, we'll make a note of, and we'll be sending out responses. All right, so we will answer everyone's question, maybe not tonight, but we will get back to people, right, and post it as part of the update from tonight. Now, I'm just picking up some questions here, which is, what do you do if you share your patient with another practice and you can't do a GP CCMP because they're registered for My Medicare with the other practice?
So that depends on who is there. They say the guidelines state if the patient is registered, it can only be provided by the patient, the GP they're registered with, or the practice that they are registered with. If they are not registered, it is their usual or regular provider. So if you are a regular provider of that patient, the problem is if they have enrolled at one practice, you will not be able to do it. It's unfortunately is the way it is. If the patient doesn't enroll, then either practice can do it because there's regular visits between the two. So I guess it's another benefit or another incentive for you to start registering your patients, particularly ones who may share their care between different providers or different clinics.
Thank you for that. And look, I just want to pick up this question on allied health, which is someone's asked, instead of putting physio or EP or podiatry on the referral, can we just say allied health provider? Or is it mandatory to put the particular allied health provider?
Well, maybe not, because you have to put in the referral letter, you have to put the conditions and I guess you could, as long as the referral still included the services that you're referring for. So that you're referring the patient because they have plantar fasciitis and they need to see regular podiatry, so there still needs to be information that will basically direct the referral. But yes, our dear allied health provider would be more than fine.
Yep. That's good. Thank you. Now, look, does there need to be 3 months between the review of the current plan and the first 765?
965, yes, absolutely. So that's another good question. So yes, if you've done a 721 and 723 today, the 19th of June, you cannot do a 965 until the 20th of September. Remember, because there's 90 days and there's 30 days in June, so it's going to be 3 months and 1 day.
All right. One in relation to practice nurses. If nurses do the new plan or review of the new plan, does the GP still need to see them face to face?
Absolutely.
On the day of billing?
Any MBS item number that is billed under the GP must see the patient, except for the COVID vaccination item number, which we're losing anyway.
Yeah. Okay. Yeah, this is an interesting one as well, I think. Will there be a time span limit for the new 965 and 967?
No minimum time requirement, as simple or as complex as the patient is in front of you.
Okay. And will the new BB incentive apply to those item numbers come November 25?
That's another bonus. Yes, the triple bulk billing incentive will apply to chronic condition management. Yep.
All right. Okay. Well, we've answered a lot of questions. We'll keep going through some of these because I think they're really adding a lot of value. Do you have any tips for registering patients with cognitive impairment?
Good question. So I guess it depends whether the GP or whether the patient is deemed as competent to sign. So if the patient is impaired to the point where they are unable to the GP determines that maybe you're a good one to answer this, Brendan, but I would say my suggestion would be if the patient is unable to sign, there is requirements around that. So you know that if the patient can't sign for themselves, that the next of kin or family member can sign for them. A medical power of attorney can sign for them. However, a GP cannot sign for them. So a GP can't say, I'll sign on your behalf. Basically, if the patient has no one to sign on their behalf, you cannot register them for My Medicare.
Okay. I think that makes sense to me. Look, I think a few people might be thinking along the lines of this next question, which is if a new plan was developed within the last 3 months, can exactly the same plan be used with the new item number?
Absolutely. If nothing has changed, absolutely. So you would basically just bill, you review the plan with the patient as you would normally, but you would then put your 965 in place. It's all about the item numbers. To continue on in the future, the 965 must be generated first, and then basically the guidelines say the 967, the 965 only needs to be billed when there's been a significant change in the patients. You don't have to do them every 12 months or 2 years, just like it is now, but we do it every 12 months or 2 years because we can. Because the remuneration is going to be the same, there's no benefit from putting in a new plan unless the patient's condition changes. Then they need to have that new plan put in place. And if it's a significant change, you can actually bill it less than 12 months. So same as now, if there's a significant change in the patient's condition, or they're currently managed with hypertension and no, that's not one, osteoporosis, and all of a sudden they develop some type of cancer, then of course the plan needs to be updated to reflect the patient's needs.
Okay, thank you for that. Will referrals to specialists also last 18 months?
No, which is a bit of it's a bit annoying.
Yes, it's a good question. Right?
I should say no, because I actually don't 100% know the answer to that. So that's something I'm going to look into, because I just made that assumption. So let's check that out. I'll get that.
After doing 5 of these, that's a new question. So, and it's one that Wendy doesn't know, which I'm surprised about. So, Wendy,
good question.
you come back to us. Now, to access Allied Health, will they need a new 965 in a year?
No, because they've got 2-year transition. So as long as a new plan is put in place before the 1st of July 2027, they can continue to access the Allied Health under, but you won't be able to review it. So there'll be no ability to review because you won't have a 965 in place.
Yeah.
So I guess it makes sense just to transition people as they come up, so that we eventually get all our patients transitioned in a 2-year period.
Yeah. Now, this next one I think is interesting. I mean, I could probably know the answer to it, but Wendy, if a patient uses the first visit with physio A and then decides to change to another physio B, do they need a review and wait for 3 months of period, or can simply go the same referral?
No, that's great. That's what that open referral is all about. And basically, the patient has choice. So the patient might go to physio A and either just feel they didn't meet my needs, I wasn't comfortable with them, I felt like it was a waste of my time, and my friend said, try physio B, he's so much better, he helped me. All they have to do is either request the referral to be resent to them from the GP, or they have if we get in the habit of emailing the referrals to our patients, they then have them, and then the patients can email on, but they keep a copy of it. So they can then use it wherever they want. As long as there's no more than 5 services accessed in a calendar year, the patient can choose how they use them.
Yeah. All right, thank you. Now, this is one that I was actually talking with the GP about today, actually. For Aboriginal and Torres Strait Islander patients, patients, do they still do a 715 in place to access the additional 5 visits?
Yes, so that health assessments haven't changed, and you do know that now with the 715 health assessment, you can also do a 699. So previously, 715s or our Aboriginal Torres Strait Islander health assessment which is billed 9 monthly, is a health assessment, and the Healthy Heart Check is a health assessment. So you can't bill them together. However, except for First Nations patients now, if they have a 715 in place first, they can then have a 699 billed 3 months later. So keep that one in mind, because that's the only exception to the rule for health assessments. But there's no changes at all to health assessments or their criteria.
Now, Wendy, just going to take it back to the Physio A and Physio B type question we had earlier. Someone's written, but if you send them specifically to Physio A, who has particular skill set, can the patient still change and then go to Physio B?
It's patient's choice. It's all about the patient's choice. So yes, they can. If the GP refers them to Physio A because they believe it is the appropriate referral mechanism or the right person for that treatment, the patient has still got the choice to say, no, I don't want to go to them. I want to go to somewhere else.
Yeah. Okay. Now, we might be able to get a few of these knocked over, I think, fairly quickly. Will there be any instance whereby a 1099.7 could be billed, could be claimed at the same time as a management plan? For example, if an ECG or a vaccination was done at the same time.
Yes. So reading that PANDAT will give you a guidance, but absolutely. So when I say chronic disease management, I'm talking about the preparation and review of the paperwork. If the nurse then goes and does a spirometry or an ABI or an ECG for that patient, that's a service on behalf of the GP, then yes, of course, you can bill the 10997.
Okay. Now, just doing a bit of a scroll up here, I think we've done pretty well on the questions. The questions are becoming thick and vast. So, Wendy, if you've got a drink of water nearby, take a drink of water before we then continue. Will the GP bulk bill the review item every 3 months?
So it is up to the GP whether they choose to bulk bill. So the chronic condition plans are not mandated to be bulk billed. They never have been. So even with 721s and 723s, you can privately charge. But it's up to your GP what your practice, what you decide to do. Some practices are choosing to do an out-of-pocket, to recoup some of the costs that they may be losing, but that is entirely up to you. There is no recommendation either way, whether you bulk bill or privately charge.
I would say it's good to see the interest in relation to allied health tonight. We've had a few questions on allied health, which is just fantastic. So who will keep track of 5 sessions if they chop and change allied health?
Doesn't matter. So basically, well, I should say it doesn't matter. So basically, if the GP gives the whole 5, it's up to the patient where they use them. If the patient chops and changes, I agree. It's up to them then to work out how many are used. And the simplest way for them to do that is to ring Medicare and ask them how many services I've had billed under the 800 item numbers or 8,000 item numbers. That's why I find it doesn't make sense for the GP not to record. You know how I said that there's no recommendation or no requirement to add the number of services you refer for, because at least if the GP says, okay, I referred to 2 to the podiatrist and 3 to the osteo, however the patient chooses, and the patient comes back and says, oh no, I ended up not going to the osteo and I went to the physio instead for the 5, the GP can update their notes accordingly, but it's got to come back to the patient on that one. Again, a bit of foresight for them. You can choose who you go to. However, please keep track of it, because you only get 5 for a calendar year, so you'll need to know who you've seen. Or they just keep going till Medicare doesn't pay them anymore. That's what I think happens. Yeah.
Okay. Thank you. I just want to come back to one of the first questions we asked, which is regarding the GP management plan that was completed, in June of 2025. With no TCA. The patient is going overseas now and will be returning on the 7th of July. What happens?
So you can transition to the new plan from 3 months from today. So if you build it today, you have to wait 3 months. If they don't need a review or they're not. So bottom line basically is from the 1st of July, anyone who is due for a review of their current care plan. So the current prior to 1st of July will need to be transitioned to the 965 first. So regardless of when they had it, if the patient returns in August and they are due for a review, which they won't quite be because it won't be till September, they will then transition to the new 965 if they come back for a review. You'll probably find, I think we're going to see the impact of this in January when our patients start to come back because they want their new allied health referrals. That's where I think we're going to really see the impact of this. Patients who have got them for this year are less likely to come in, whereas come January, you know what it's like, all of a sudden you get every second patient wanting a care plan because they need they don't even understand half, and they just want whatever I have to do to get my free visits or my subsidised visits.
Yeah. Now we're coming up to the end here, but how should we bill if a patient has a procedure and then comes back for a wound check?
A procedure as in a surgical procedure?
I would think so, yes.
All right, well, I can certainly answer that one. So if you do I don't know, biopsy today and you bill a 30071 because you are pretty confident that you've either got it all or you don't intend to do anything about it, and the patient comes back tomorrow for a wound check, you cannot charge them. If, however, you're another doctor, if it's just because you want them to pop back in to make sure that it's not bleeding, and you're saying just pop back in, we'll check it out, you'd get the nurse to check it, and the nurse would buzz you, say, can you pop around, I've got the dressing changed. If it's another GP, so Dr. A does the procedure today and Dr. B reviews for the wound, then absolutely that doctor can charge a time-based consultation. But Medicare services, particularly around surgical, have that aftercare period. So if you're doing a biopsy, it's expected that you would, what's not expected is that patient's wound would bleed so profusely that they had to come back. Then you could bill an item because that's not expected. But if you are requesting the patient just to come back tomorrow so you can check it, you can't charge Medicare for it. But another GP can. I hope that answers that question.
I think it does. So look, I'm just going to go at it and saying, Wendy, can I say, wow, your knowledge of the item numbers is extraordinary.
I've been here a long time, Brendan.
Well, I won't comment on that. All I'm saying is that your knowledge is fantastic, and so we're incredibly grateful. I'm just doing a final check now through some of the questions. So, now, so someone has said, excellent presentation, and it absolutely has been. Will any CPD points be automatically sent to the RSCGP? That might be one for Jan, actually. Do we need to self-log for this webinar? Well, Bertha's answering that. Sorry, my apologies. And yes, thank you for the comment around Kayla. Kayla's absolutely on the tools tonight and doing a great job. And I think the previous comment around the procedure was in relation to that it was a surgical procedure. So I'm hoping the answer has clarified that. So I think we're almost got most of the questions answered. Okay, we might go to this last one, I think, which is, once the GP registrar leaves the practice, any patient who registered for My Medicare under them, their status on our says PROTA says it is expired. Can we presume that they are still registered with My Medicare at our practice?
No, you can't. Unfortunately, if the GP has left, the registration becomes void and you have to contact the patient and say, you were registered with Dr. A. Unfortunately, Dr. A has left our practice. Do you have another provider you would like to register with? And you would have to, which you can do quite easily on PROTA, just by going to their details, edit and select a new provider from the date. The patient should also get a text message. So when a provider leaves the practice, the patient who is registered with that provider will get a text message through MyGov to say you will need to re-register for My Medicare because your selected provider is no longer practicing at the practice you are registered at. So they will get notification. What we tend to do when a GP leaves is I run a list of the patients who are registered with that GP, and I contact each of the patients and say, just letting you know that Dr. Smith unfortunately has left our practice now. Do you have any idea who you'd like to see in the future? Or, and if not, we basically leave it till they come in, the next practitioner provider, and put a note in their file to say, needs to have my Medicare updated. So it is a bit tricky, and particularly around registrars. So getting registrars, running that list when the registrars leave and contacting those patients quickly allows you to get that solved quickly.
Now, Wendy, we're coming up to time now. I think we might take the rest of the questions on notice and we'll send out responses. If we've got ones that our team, Carol and Jan and Amy, I'm not so sure about, we might flick them on to you just to double check them. We don't want to give out wrong information. Can I say a fantastic presentation tonight? We're seeing comments in the chat on that, and people are incredibly grateful for just your deep knowledge and also your practical wisdom that you've been able to apply tonight. So we're grateful. Can also extend my thanks to the assessment team, Jan, Kayla, and also Amy as well. These are the guys who keep us running. So thank you for that. Please complete the online survey that'll pop up in your web browser. You'll be hearing a lot more from us on these things. So we know that practices are needing a fair amount of support. These are big changes. And so our role is here to assist. So can I draw to again, Wendy? Thank you for that. Thank you to the assessment team. And well done. And I wish everyone a good night.
Thanks, everyone. Thanks for joining.
Thanks, everyone, coming along.